Okay, we welcome the entire the faculty and delegates who have logged in from all over the world for this international webinar series 4. I am Dr. T.S.
And it's a living document, as I told you. And they have very systematic evidence-based grading, because when we talk of guidelines and recommendations, I'm sure in the gastroenterology world also, there are A, B, C, and E. E means it's expert consensus or clinical experience. C is probably poorly controlled or uncontrolled studies. B is well-conducted cohort studies or a registry or an evidence from a well-conducted meta-analysis of cohort studies. And when it comes to level A, well, it's a well-conducted multi-center RCT or evidence from a meta-analysis from incorporating quality rating analysis with well-conducted high-powered trials. So, this is the entire table of contents for that. And I'm going to scope myself on areas of type 2 diabetes, but some other areas which ADA focused on this year. So first is diagnosis, and we know that we need fasting, postprandial, and GTT, and we need a diagnosis of hyperglycemia. So often that is missed out. But A1C has been an integral part of diagnosis worldwide, including India. But in India, we don't use A1C as a diagnostic label. And it's very important to recognize that low hemoglobin alters the A1C. There are hemoglobin variants which are prevalent in India. We get a lot of hemoglobinopathies. Pregnancy, postpartum. Hello? Am I unmuted now?
Sir, you're unmuted, sir. You can carry on.
Yeah. So I think it suddenly got muted. So A1C is an important diagnostic tool. The only thing I wanted to get into attention of gastroenterologists is you often see anemia. So whenever there's anemia, the A1C will be falsely high. Whenever there is hemoglobin variants, G6PD deficiency, HIV hemodialysis, a recent blood loss or transfusion, hemolysis, erythropoietin therapy, you will often get a wrong A1C result. And I won't go into criteria, but then we need to diagnostically do cluster classification. There are 4 types of diabetes. I'm going to focus on type 2, but there is type 1 where you need to do an absent C-peptide, an antibody which is positive. It is also seen in adults. So a lot of people, if multiple drugs don't control their A1C, their C-peptide is low, their GAD antibody is positive, they are type 1. Then the third type of diabetes is secondary diabetes, which often you see due to diseases. As a gastroenterologist, you need to know of pancreas, exocrine pancreas, drug-induced diabetes, chemical-induced diabetes, pancreatectomies. So that is the secondary diabetes, as they call it. And in India, we have been having variants of the fibrocalcific pancreatic diabetes and malnutrition-related diabetes and so on and so forth. And sometimes now, the IDF, which recently concluded in Bangkok 2 weeks back, said that the secondary diabetes or MRDM is type 5 diabetes now. So they new term which is there. And that is often secondary diabetes due to diseases of endocrine and exocrine pancreas. And then, of course, they have also nicknamed diabetes called type 4 diabetes, which is gestational diabetes. So we have type 1 diabetes, which is autoimmune, no beta cells. Then type 1.5 diabetes, which is autoimmune diabetes of the adults, called LADA, latent autoimmune disease of the adults. That's type 1.5 diabetes. Type 2 diabetes is basically what I'm going to discuss, which is insulin resistance, abdominal obesity, metabolic syndrome, and adequate C-peptide or high C-peptide. Then type 3 diabetes is nothing but insulin resistance of the brain. It's not a diabetes at all. It's Alzheimer's disease. Type 4 diabetes is secondary diabetes of MRDM or diseases of the pancreas. And type 5 diabetes is the disease of the pancreas. Type 4 is gestational diabetes. So 1, 2, 3, 4, 5 is how it has been labeled now. So fundamentally, we need to eliminate type 1 diabetes by doing antibody testing and C-peptide testing. And you can grade that autoimmune. So it's an autoimmune disease. Type 1 diabetes is a clear-cut autoimmune disease, and there are stages of this autoimmunity. The diabetes which you need to focus on as gastroenterologist, which is there in the new guidance, is pancreatic diabetes or diabetes in context of exocrine pancreas. And if there is an episode of pancreatitis, acute pancreatitis, there is a now recommendation with a level of evidence of E for acute pancreatitis that you need to screen that patient annually for diabetes. And you know that pancreatitis both acute and chronic, is on the rise worldwide, including India. And therefore, it's important and pertinent for gastroenterologists to recognize that you should be mindful of screening every person with an episode of acute pancreatitis and every person living with chronic pancreatitis annually for diabetes. We also see post-transplantation diabetes mellitus. And we are seeing more and more transplantations and organ transplants being there. And due to the immunosuppression, we often see a lot of PTDM, which is post-transplantation diabetes. It behaves very much like an extended arm of type 2 diabetes. So we should be mindful of that. And, because a lot of you all are from South India, we also see monogenic diabetes syndromes. Normally, type 2 diabetes is polygenic, but we do get these MODY genotypes. Basically, this is autosomal dominant, age of onset is less than 25, 3 successive generations, and they have good C-peptide on board, and they're usually ketosis resistant. So if you get a person with 3 successive generations of diabetes, age of onset of diabetes less than 25, usually an autosomal dominant, you can actually do a MODY gene, and they can respond very well to sulfonylureas. And these are the genotypes which have been identified, and I don't want to go into details. So when you come to type 2 diabetes management, the key is lifestyle. And lifestyle is all about behavioral change. We are getting type 2 diabetes mainly because we eat too much and we have become very sedentary and we have become very affluent. So fundamentally, the lifestyle behavioral change as per the recommendations as of 2025, we are talking in the end of April. Clearly, we know that we need to reduce body weight, which Dr. Lakshmanan very rightly highlighted. And then we need to prescribe a diet. We need to write on the prescription, eat slowly, eat on time, eat less, eat right, do physical activity, at least do 10,000 steps, do some strength training, muscle building exercises, and at least sleep for a good 7 hours. That becomes a prescription. So lifestyle behavioral change is key for type 2 diabetes prevention and has to be a prescription, and it should be given by the medical doctor, and it's a very key component. Then, of course, we have pharmaceutical interventions. To delay or to prevent diabetes, we have pharmaceutical interventions. The most classical of that being metformin, which is the most well-studied. We will have dialogue and discussion on metformin. Metformin is old wine in new bottle. Metformin is a wonder drug. It is an anti-aging drug. It's a bigunide. It does cause GI intolerance in 1 in 50 to 1 in 100. It does cause B12 deficiency in the predominantly vegetarian Indian population. And I'm sure we'll have dialogue and discussion on metformin. But it does, in 1/3 of cases, prevent type 2 diabetes if you are in pre-diabetes, while lifestyle will prevent type 2 diabetes in 2/3 of cases. And now we have other drugs like pioglitazone, which is an insulin sensitizer, like the SGLT2 inhibitors and the GLP-1 receptor agents, which may have a role in prevention, but the evidence based on that is weak. We also need to save lives, and we need to have a world free from type 2 diabetes complications. And therefore, it's important to recognize that most people living with diabetes have a shorter lifespan. On an average, a person living with type 2 diabetes lives, on an average, independent of genders, around 6 to 10 years less than normal population. And their death is predominantly through the heightened cardiovascular risk. And our risk factors are modifiable. So it's important to recognize, to identify them, and then prevent those risks of myocardial infarction, of stroke, of peripheral vascular disease, and so on and so forth. And many agents have been implicated in prevention of the same. The goals of care in the 2025 is all personalized. It is all individualized. So if somebody has limited life expectancy, is living with a terminally ill cancer, probably your A1C goal will be probably 7.5 or 8, and you may go for less diet control. Somebody, a non-pregnant adult, the goal for treatment has to be less than 7%. You have a young person without any complications, then the goal should be around 6.5. So it's a changing goalpost. In the good old days, we used to say stick to A1C below 7%. But today, we say try to ensure that you individualize the person-centered goals. And we also have ability of technologically measuring the glucose in range, which is called time in range. And we try to keep the time in range in the green zone as much as possible through CGM. And we also have a new term called time in tight range, which is something which we recognize better. So it's important to recognize that we need to control the glucose based on profiling, based on person-centered goal and individual goals. Of course, in type 1 diabetes also you can delay by giving a teplizumab infusion, which is a monoclonal antibody, which can actually delay and defer. And these are infusions to be given twice a day for 14 days. So in type 2 diabetes, what is the core? The core is all about individualization. There are two goals of care. Dr. Lakshmanan very nicely told us. Number one, prevent complications. Number two, optimize quality of life. So the first thing is individual priorities. Look at the lifestyle and health behavior. Look at comorbidities. And the fourth comorbidity which has got added, one is of course cardiovascular risk, the chronic kidney disease risk, and the heart failure risk. And now they have added also liver component. Look at the age, A1C, and the weight. Look at issues of motivation, depression, and cognition, and look at social determinants of health. Then you try to individualize glycemic goal and weight goal, try to avoid hypoglycemia, and protect heart, kidney, and the liver. Try to ensure that the side effect profile of medication is studied. Try to keep a very simple plan and look at affordability costs. Remember, diabetes management in 2025 is shared decision making. You have to sit with the patient and the caregivers of the patient and yourself and make out a smart plan. The smart plan which is recommended is specific, measurable, achievable, realistic, and time limited. And this is how the AD has delineated a smart plan. And we have to get the patient or the person living with diabetes and their caregivers to agree to get into those smart goals. And then implement that management plan and also look after not just giving them medications and exercise prescription and forget about it or lifestyle prescription, but also handle their emotional quotient, handle the tolerability to medications, revise them, look at the biofeedback after a value from a glucose meter or a CGM comes, look at weight and step counts, and then keep on changing and modifying the management plan based on the individual patient. We need to ensure that every person living with diabetes gets adequate immunizations. We have a plethora of immunizations. I will not go into details of that. And of course, now in the guidance, and I'm not going to dwell on this, is an important algorithm for MSLD, which is now incorporated in 2025. And we clearly recognize that we need to filter it to the various scores. And I'm sure our next speaker will allude to that. And I'm not getting into this space at all. It's very important to recognize that we live in a country and worldwide people are looking at fasting. And fasting is something which we know has two issues. One is religious fasting. Sometimes the Ramadan fasting, the Lent fasting, the fasting in the Hindu religions. Every religion has fasting. And usually religious fasting is fixed duration and timing. It is highly motivational. There's a risk of hyperglycemia and with or without ketosis and ketoacidosis. And dehydration is the key. So you need to identify and delineate that risk. There's another popular variant of fasting, which is called intermittent fasting, which has become a fad. It is not highly evidence-based. There is a risk sometimes, but the risk of dehydration is much less. And we need to ensure that the hypoglycemic risk, the risk assessment and the treatment adjustment is modulated as per the type of fasting. We have a third variant of fasting because we are living in a digital world and we are talking through a Zoom virtual mechanism. It's called as a digital detox or digital fasting, where we try to declutter our minds by being off various social media and devices. So in the modern management of type 2 diabetes, your success will only come if you individualize your care. And in that, there is a simple risk calculator. For example, if you are looking at a person to be evaluated for a fasting, before fasting like Ramadan, then first classify the diabetes. Is it type 1, type 2? What is the duration? Is it more than 10 years or less than 10 years? What is the presence of hypoglycemia? Is that person not understanding he goes into hypoglycemia? It's called hypoglycemic unawareness. Look at A1C. Is it above 9%? Is it 7.5 to 9? Is it below 9? Look at different types of treatment. Look at whether the person can, monitor. And then are there acute complications? Are there complications which are and comorbidities which are stable or unstable? Look at the renal risk. Look at whether the person is pregnant? Is a person frail or has memory issues? Is a person an intensive laborer or a moderate laborer? And has he fasted in the past? We should also be mindful of the fact, because we are talking to gastroenterologists, that smoking cessation, tobacco, e-cigarettes, and cannabis all need to be eliminated. And then we need to promote physical activity. And there are 5 S's which are very well recognized by the American Diabetic Association. First is sitting is the next smoking. So limited sitting, breaking up prolonged sitting every 30 minutes will allow you to live long. Sweat it out. If you sweat it out, you do physical activity, it is going to improve you. Then step, every 500 steps will decrease 2 to 9% of cardiovascular morbidity. 5 or 6 minutes of brisk walk is equal to 4 years of added life expectancy. Finally, you need to do muscle strengthening exercises, because we are increasingly seeing sarcopenia, which is muscle loss and frailty. And it's important that resistant exercises are very important, particularly after you age. And the last part of the S is sleep. You need at least more than 5 hours of sleep and less than 10 hours of sleep. We need good quality of sleep, and the sleep chronotype matters. It's very important to recognize that. And therefore, we have to identify the goals of the patient. As I told you, if person is old, very complex, poor health, limited life expectancy, there is no A1C goal. If there is an older adult with complex intermediate health problems, the A1C could be less than 8%. If the person is a healthy older adult, try to keep your A1C between 7 to 7.5. And if the person is in good health, low treatment risks, burdens, then you have a A1C below 6.5%. So the longer the diabetes duration, higher the hypoglycemia risk, high treatment risks and burdens, pharmacotherapy or non-glycemic benefits, established cardiovascular complications, less stringent goal. If you have short duration of diabetes, low hypoglycemia risk, low treatment risk, multiple comorbidities, then very, very, very strong aggressive goal. We need to manage crisis. We should be mindful of crisis like diabetic ketoacidosis and hyperosmolar states. And we also need to know that these glucose meters in the ICUs, as well as monitoring systems, sometimes can give you false high glucose values. For example, maltose, galactose, xylose, paracetamol, dopamine, furosemide, vitamin C, uric acid, low and high hematocrit can falsely increase or decrease the glucose values and N-acetylcysteine. So we should be mindful of all the substances which interfere with glucose meters. And many of these are very commonly used, including hydroxyurea, sorbitol, mannitol, and paracetamol. We need to use digital health effectively, but we should not get digitally intoxicated. I see many people have CGM and they keep on scratching it all the time. Many times the CGM values underread their diabetes, but they are very good for remission. I work with a Chennai-based startup where we do digital remission through digital twins. We also recognize that some people are insulin deficient and they may need insulin, so don't hesitate to use insulin. And some people may have severe metabolic complications or severe kidney disease, and we may look at even beta cell replacement options. But remember, the key today in type 2 diabetes management is about individualized care. So when we are looking at person with atherosclerotic vascular disease, first healthy lifestyle, then self-management, education and support. Then if there's atherosclerotic vascular disease with high cardiovascular risk, our first choice agents are GLP-1 receptor or SGLT2 inhibitors with proven cardiovascular benefits. If there is heart failure, it's SGLT2 inhibitors. If there is CKD, then SGLT2 inhibitors come up on the pecking order as long as the eGFR is about 20, and or GLP-1 receptor agents with proven cardiovascular benefit. If weight management is the issue, then we go for the GLP-1 receptor agent, which are now available, on a hierarchical preference of tirzepatide, semaglutide, dulaglutide, liraglutide. And then we go, of course, for SGLT2 inhibitors. And then, of course, euglycemia at an effective cost. And, of course, the efficacy of glucose lowering also is being considered. In the mitigation of risk today, because I am addressing an audience from the gastroenterology world, you need to understand that the ADA recommends agents with potential benefit for MAFLD and MASH. And in that, they have actually used a group of agents. Number one, GLP-1 receptor agents like a semaglutide or liraglutide. dual GIP-1, GLP-1 receptor agent like tirzepatide, pioglitazone, or a combination of a GLP-1 receptor agent with pioglitazone. But they have said if there is a setting of decompensated cirrhosis, there is no role for any of these agents, and please use insulin. That is what the latest guidance is very, very clear. Fundamentally, it's not just about glucose management. It's blood pressure control, lipid control, and agents with cardio-renal benefit, apart from lifestyle, education, and management. And then when we are plotting the graph, the first line therapy now, beyond healthy eating, physical activity, tobacco or smoking cessation, weight management is that it's going more and more towards metformin and SGLT2 inhibitors, then RAS inhibitors and statins. That's the ABC with diet and exercise. So A is for A1C, B is for blood pressure, C is for LDL cholesterol, D is for diet, E is for exercise. And then, of course, you can up titrate the medications accordingly. The 4 M's, which are very important in diabetes management, is number one, mental health. Because people self-administer medications, and how you can tap technology for better ones, and how you can reduce distress, depression, and anxiety, and also eliminate cognitive impairment and dementia, and understand coping skills and self-care. So mental health is a key, and you need to evaluate it in your day-to-day care in diabetes management. Number 2 is medications. Try to simplify management. Try to ensure that there is a continuous supply of medications and mitigate hypoglycemia and adverse events. Number 3 is mobility. If there are food complications, functional or frailty or sarcopenia or leg weakness or neuropathy or vision or hearing impairment, then you can't encourage physical activity. You need physiotherapy assisted care. And what matters most is be realistic in discussing goals and expectations, symptom and disease burden, meal and treatment preferences, risk burdens and benefits, and life expectancy. And then ensure that it is titrated as per the A1C. A1C below 8.5, no acidosis, ketosis, you can start with metformin and then move on, and so on and so forth. Of course, pediatric care is a different ballgame altogether, and insulin care is a different ballgame. But the bottom line is make it work. In the last 5 minutes, I'm going to be India specific. So the global audience, I would beg your pardon, but we need to make it work. That's the goal. So India has exploded. This is the ICMR India report. Dr. Mohan from Chennai is the lead author on it. I am the PI from our state, Maharashtra. And you can see India has now 101 million people with diabetes, 136 million people with pre-diabetes. And this number is based on GTT. If we do A1C, this number becomes 200 million. And Dr. Anjana and Dr. Mohan are authors on that paper from Lancet also. So India is the largest burden of diabetes on planet Earth. We are different because we have a different phenotype. We are thin fat Indians, and we definitely need to ensure. But our current model of care in India has to be cardiometabolic. We have to ensure that diabetes has to be treated, and obesity and diabetes has to be treated. And we don't look at only BMI because we are thin fat Indians. We have to ensure that the adipose tissue of fat is burnt out. So the modern type 2 diabetes management is not just glucose centric. It is weight centric, cardio centric, and obesity centric. And we need a weight centric approach, and that has to be the standard of care. And therefore, the global guidelines, like the RSS, the ESI wheel is there. The IDF just guidance has come out. The AS has come out with their own guidance. They look at these 5 points. Modify lifestyle, try to decrease complications, try to halt progression of disease, try to keep it affordable and accessible, try to be mindful of comorbidities in elderly, and mitigate the pill burden. And simplify management. Glucose, no hypoglycemia, no weight gain, ensure that the comorbidities of liver, kidney, and heart are taken care of, and people can take their medications long term. We have a different phenotype, and we can see the entire spectrum in our clinic: malnourished patients, lean patients, overweight patients, morbidly obese patients. How are we different? How is India different from India? Well, we have lean and non-obese patients, but they are still having body fat inside their body. Unless the person's BMI is less than 19, between 20 and 25, they will still have insulin resistance and they'll still respond to metformin, except if the BMI is below 19 or 20. Secondly, we are ketosis prone because a lot of our patients stop medicine suddenly when they become okay. They use steroids, maybe large steroids. We use a lot of cold drinks now in summer seasons, and you can see that they come with ketosis. and this is the ketosis prone variant. And remember, in India, we also use drugs like alpha glucosidase inhibitors because we eat a lot of starch. And we also use a lot of sulfonylureas in our management. And our BMI cut points are different. So remember that in India, we are a little different. And therefore, the current approach to diabetes management is not a downstream approach. It's an upstream approach. We try to attack and chop off the fat because then we can impact sleep apnea, hypertension, NASH, MASH, osteoarthritis, dyslipidemia, diabetes, and reduce complications from that route. And that's the one thing. The biggest agents which have come in, and I'm sure my next speaker will allude to it also, are the GLP-1 receptor agents. They are the game changer agents. They make you lose weight and they regulate blood pressure, glucose, lipids, and various other activities. They have excellent CV outcomes and they are great agents. And they're single agents, they're dual agents, they're triple agents. And we have a huge choice of drugs today for glycemic control. And you can see that in the last 20 years, there's an explosion of drugs which have come in, but still our control of diabetes in India is very poor. So my last couple of slides are that one size doesn't fit all. We need good glycemic control, but we should always look at patient safety and we should individualize treatment. And that's very, very important to recognize. Finally, nothing works without lifestyle and without prevention. And remember that we all need to look at doing 1 hour of digital detox. We are all committed to health and happiness. Remember, outcomes are not only about health. They are health and happiness. And therefore, we need to eat less. We need to eat on time. We need to eat slowly. We need to do a lot of physical activity, including yoga, strength training exercises, all the four S's which I talked about, including good sleep. And of course, we should be stress-free and smile. Thank you so much for a patient hearing. I'm sure there'll be a lot of discussions. In 30 minutes, I tried to do the best I could so that I could give you a crystal ball view of what's happening in the type 2 diabetes world in terms of evidence base. And I hope that I've done some justice to the topic. And I'm sure during the dialogue and discussion, we will be able to get some more insights. I'll be happy to all answer the questions after the second speaker. I'm looking forward to Dr. Raja Yogesh's talk. And I'm sure that you will have some fruitful hearing. I hope that whatever little you learned from me, you can adapt it into your day-to-day care, because we all have a common goal, which is to ensure that people living with diabetes get good care and they are able to live long. Thank you.
Thank you, Shashank. I think it's an excellent erudite talk. We'll take the question and answers later after the talk from Dr. Raja Yogesh. Hand over the mic to Sandar Shekhar now.
Yeah. Thank you, Professor Lakshmanan. I think you will agree with me, and along with others, Dr. Joshi has made it as simple as possible. At the same time, the complicated topic made very, very vivid, and he made it very, very simple. But it is not as simple as when you start hearing to the thing. Probably he didn't want to complicate too much about the complications in diabetes, but we have a lot of questions to you. And now I pass on the mic to Dr. Ganesh, who's my friend, who is going to moderate, introduce the topic and introduce the speaker. Dr. Ganesh, please.
Good evening, all. That was an excellent lecture by Dr. Shashank. Very wonderful, very informative. I will go on to the next speaker, and I have pleasure in introducing Dr. Raja Yogesh to talk on diabetes and GIT. We know that diabetes can significantly impact the GI systems and can cause a wide range of GI issues due to nerve damage and altered gut function. Diabetes and gut are closely linked, and gut microbes play a very significant role in glucose metabolism and insulin sensitivity. We look forward to Raja Yogesh to deliver his lecture. Raja, the floor is yours.
Thank you very much, sir, for the kind introduction. I was awed by the lecture by Professor Joshi. It was quite an eye-opening experience for all of us. And let me dive into my topic. So I'd be speaking on diabetes and how it affects the GI tract. So let me move on to the presentation. I hope you can see the presentation.
Yeah, you can. You have to.
Okay. So diabetes and the GI tract is my topic, and we'll be discussing on how diabetes will be affecting the GI tract. course, we know that diabetes is a disease which can affect any part of the body. And coming to the GI tract again, it can affect the oral cavity, the esophagus, the stomach, right up to the anal canal. Starting with the oral cavity, it can present as a symptom with dysgeusia. Diabetic periodontitis is very common. Oral candidiasis, and patients can also have a salivary gland dysfunction. Coming to the esophagus, you could have candidiasis. There's a wide risk of patients having dysmotility, which in turn predisposes them to pill esophagitis. Even gastroesophageal reflux disease, and more commonly erosive disease, is more common in diabetics as compared to non-diabetics. Coming to the stomach, we can have gastroparesis, or in type 1 diabetes mellitus especially, autoimmune gastritis is indeed quite common. Coming to the intestines, we can have diabetic enteropathy, and in itself, we can have diarrhea, constipation, and fecal incontinence. So you have a wide range of GI manifestations or GI afflictions because of diabetes mellitus, and each organ would be a topic in itself. And for the sake of time, I'll restrict my discussion to just gastroparesis and diabetic enteropathy or diabetes-induced diarrhea here. So what are the mechanisms by which the gut is influenced by diabetes mellitus? So we can have enteric neuropathy, that is the prolonged hyperglycemia affects the neurons of the GI tract. Then it can result in disordered motility, either hypomotility or hypermotility. Patients can also have dysfunction because of immune dysregulation, either hypo-regulation or misdirected immune regulation. And a lot of GI side effects are because of the drug-induced side effects because of the diabetic medications as well. So we'll start with diabetic neuropathy. Of course, diabetic peripheral neuropathy is very well known, whereas when it comes to enteric neuropathy, it's almost least talked about and not very many people know about it. So what is enteric neuropathy? We'll start with the enteric nervous system. So the enteric nervous system is also called as a second brain. It's the personal brain or the individual brain, which is autonomous to the GI tract. So it doesn't have much of an interaction with the central nervous system, and it can function almost autonomously. It can have 100 to 500 million neurons. It's nearly has twice or thrice the number of neurons which are present in the spinal cord. And it functions by using more than 30 neurotransmitters, and nearly 90% of the neurotransmitter, which is 5-hydroxytryptamine, is found in the GI tract. So this second brain is, where is it exactly present? It's present in the form of a plexus. There's one plexus in the submucosa, which is called as a submucosal plexus. And then we have the second rich plexus, which is between the circular and longitudinal muscles of the GI tract, which is called as the myenteric plexus. Apart from this part of the enteric nervous system, we also have the interstitial cells of Cajal. These are specialized cells. These are not exactly neurons. These are similar to the sinoatrial node cells, which can generate impulses on their own. And these impulses can later on get transmitted or get transferred to the submucosal plexus, resulting in continuation of the neural excitation. So these are called as a pacemaker cells. And in diabetes mellitus, when it comes to diabetic enteropathy or diabetic neuropathy affecting the GI tract, diabetes can affect either of the plexus, as well as it can affect the pacemaker cells of the GI tract. So we'll start with the diabetes and how it affects the stomach. So the most common manifestation would be a diabetic gastroparesis. So diabetic gastroparesis is said to occur in diabetes when there is delayed gastric emptying in the absence of a mechanical obstruction, that there is no stricture, there's no mass, there is no occlusion because of a chronic duodenal ulcer, but still the patient has a delayed gastric emptying. The incidence is nearly 10 to 50 times as common as compared to a non-diabetic individual. And we have definitive known risk factors for diabetic gastroparesis. So predominantly, most commonly, it is a function of the disease duration. Greater the duration, greater the risk of diabetic gastroparesis. Patients having an erratic glycemic control, again, are at risk for diabetic gastroparesis. Presence of cardiovascular risk, presence of peripheral neuropathy and nephropathy are also risk factors for having diabetic gastroparesis. Female gender and the presence of obesity are individual risk factors in patients with diabetes who can suffer from gastroparesis. Before going to the gastric dysmotility or diabetic gastroparesis, let's discuss briefly on what is gastric motility and how it normally functions. So in the fasting state, what we have are the migratory motor complexes. That is, in the fasting state, it is not in the fed state. There are small impulses which get generated from the pacemaker region of the stomach. This is located between the fundus and the gastric body. And these cells generate slow impulses at the rate of 3 cycles per minute. These are slow cycle waves, which can set about just a minute. These are slow cycle waves around 3 cycles per minute. It keeps generating. The predominant function of these slow waves is to push out whatever which is undigested during the fed phase. So after the fed phase, after the greater part of the food is digested, if there are any undigested leftovers, this migrating motor complex takes care of it and pushing it out into the duodenum. So this is the pacemaker's region, which is important for generating these impulses. Next, we go on to the fed state. So what happens once we take in a meal? So the first thing which happens is a fundic relaxation. That's most of the food gets accommodated in the fundus. And because this happens because the fundus relaxes and accommodates all the food. So this results in accommodation without any increase in pressure within the intragastric system. So this is a vagovagal reflex, predominantly mediated by the neurotransmitter nitric oxide. So after this fundic relaxation comes the second phase, which is fundic contraction. That is, the fundus contracts and pushes the food into the gastric body and antrum. Here is when the peristalsis starts between the gastric body and gastric antrum. It is important to remember that this happens when the pylorus is fairly closed. Because the pylorus is fairly closed, a lot amount of antral churning and mixing is happening, because of which food is broken into smaller particles. So it predominantly acts to mill or triturate the food into chyme. So after this phase comes the third phase, which is the phase of antral emptying. Here the pylorus relaxes and there is a coordination between the antrum and the pylorus. That this pylorus relaxes, and when there's antral contraction, small amounts of aliquots of chyme enters into the duodenum. So this happens in small quantities so that finally the entire food is passed on from the stomach in the form of chyme into the duodenum. So let's discuss with what happens between gastric emptying and the So what happens between gastric emptying and glycemia? So once the food enters from the stomach into the small bowel, it results in relative hyperglycemia. This sets about certain gastrointestinal hormones. So predominantly increase in CCK, peptide YY, and GLP-1. So this in turn results in reduction of gastric emptying. That here we see that relative hyperglycemia reduces gastric emptying. So this relative hyperglycemia also sets about counter-regulatory measures. That is, relative hyperglycemia, there is increase in GLP-1, GIP. These are both insulinotropic and glucagonostatic. So what they in turn do is that they increase the amount of insulin, increase the amount of amylin, and also reduce the amount of glucagon in the system. This in turn will result in relative hypoglycemia. And once there is relative hypoglycemia, this increases gastric emptying. So you see that hyperglycemia reduces gastric emptying, whereas the counter-regulatory measure would be to increase gastric emptying when there is a relative hypoglycemia. So what happens now when there is gastroparesis? So many mechanisms operate over here. First, we know that hyperglycemia directly retards gastric emptying. This is predominantly mediated by GI hormones. Next, we can have autonomic neuropathy. This is because of chronic hyperglycemia, which results in loss of cells in the sympathetic ganglia, vagal fibers, and there is a fair amount of evidence that there is demyelination and axonal degeneration within the autonomic nervous system. There's also evidence to suggest that there is loss of ICC. That is, we learned about the migratory motor complexes. And because of loss of ICC, these migratory motor complexes are not set in, this resulting in gastric arrhythmias. There's loss of normal MMR, that is migratory motor complexes. And this increases the risk of bezoar formation. We know bezoars are chronic intragastric structures which formed because of delayed gastric emptying in the long run. There can also be relative relaxation. There is a reduction in the relative relaxation of the fundus, receptive relaxation of the fundus, resulting in patients reporting early satiety and patients having a sense of discomfort immediately after taking food because the pressure actually doesn't relax because of the absence of fundic relaxation. There can also be pylorospasm. Pylorus goes in for a prolonged intermittent contraction, and there is also evidence to suggest that there is increase in the basal tone of the pylorus itself. There's also gastric smooth muscle dysfunction resulting in fibrosis of the pylorus. Apart from these factors, which are directly related to the diabetes mellitus, we can have drug-induced gastroparesis. GLP-1 analogs, agonists can cause and can also worsen gastroparesis, because one of the primary actions by which GLP-1 reduces blood glucose levels itself is by reducing the gastric emptying. What are the symptoms and presentation of gastroparesis? Of course, these are not very distinct from the usual functional dyspeptic patients that we have, but a fairly large number of patients report with nausea and vomiting. Also, do patients have early satiety, prolonged fullness, abdominal bloating, epigastric discomfort or pain, and nearly 50% of the patients do complain of weight loss. One interesting phenomenon in patients with gastroparesis is that they can have an unexpected postprandial hypoglycemia. This holds good for especially for patients who are taking insulin. This is because there's a delayed gastric emptying, delayed delivery of glucose into the intestines, and there is an insulin and glucose mismatch because of the reduction in gastric emptying. So this is an interesting phenomenon which can happen in gastroparesis. Now, how do you go about evaluating diabetic gastroparesis? History-wise, look for alarm symptoms. It may not just be a patient who's diabetic who's having gastroparesis, it could be also malignancy. So look for alarm symptoms, look for the drug history. Next is look for examination-wise, look for coexisting peripheral and autonomic neuropathy. In few cases, we can come across patients having visibly bloated or distended abdomen, and succussion splash can rarely be present. And coming to the metabolic profile and CBC, glycemic status, and thyroid function test, look for anemia. Again, this would show up as an alarm symptom, showing that it might not be a simple diabetic gastroparesis that we're dealing with. Patients having hypothyroidism also can have coexisting gastroparesis because of that. An ultrasound abdomen would be indicated, especially if there's abdominal pain, just to rule out any biliary or a pancreatic pathology. Upper GI endoscopy is an investigation that anybody with diabetic gastroparesis or any gastroparesis for that matter has to undergo. And if at all you find food which is in the stomach nearly 12 hours after fasting, that is itself is indicating a gastroparesis rather than a functional dyspepsia. So what are the specialized investigations that the patient with suspected diabetic gastroparesis has to undergo? First, we have tests to assess gastric emptying, and we have tests to assess the myoelectrical activity. Akin to what our cardiology colleagues can, just to give that analogy here, the test to assess gastric emptying is something like an echo. It tells us about the functional status of the stomach, how much of stomach gastric contents are emptying in a period of time. Whereas a myoelectrical activity is similar to an ECG. It just measures the electrical activity which is originating from the stomach. So test to assess gastric emptying scintigraphy is a gold standard test. Of course, we do have other tests like wireless motility capsule and gastric emptying breath tests, which are not as popular. Test to assess myoelectrical activity is the electrogastrography. So we'll first discuss the test to assess gastric emptying. Of course, I'll be discussing only the gold standard here, which is the gastric emptying scintigraphy. So how is it done? So a test meal of 255 kilocalories is given. And this test meal is labeled with technetium 99. And after giving this meal, using a gamma camera, imaging is done at 0 hours, 1 hour, 2 hours, and 4 hours. The preconditions before doing the test is that the patient has to be relatively euglycemic. So blood glucose levels have to be under control because, again, we already saw that hyperglycemia will directly influence the gastric emptying. So any glucose levels greater than 275, this test should never be done. Preferably, it has to be less than 200 milligrams per deciliter. Of course, it goes without saying that we have to discontinue drugs that can affect gastric motility, predominantly anticholinergics, and we should also discontinue prokinetic drugs also because that can directly affect the gastric emptying time in scintigraphy. So how do you interpret the results? Greater than 60% reduction at the end of 2 hours or greater than 10% reduction at 4 hours indicates gastroparesis. And if it's greater than 20% retention at 4 hours, it indicates severe gastroparesis. So this is an example where you can see that at the end of 4 hours, that is 240 minutes, nearly 22% indicating a severe gastroparesis. So coming to the second set of tests is the electrogastrography. So how is it performed? It measures the gastric myoelectrical activity by placing surface electrodes over the surface of the abdomen. So electrodes are placed over the surface of the abdomen, and the normal electrical activity is measured. You know that the normal cycles, it's around 2.5 to 3.7 cycles per minute. And any arrhythmia, it can be a tachyarrhythmia, what is called as a tachygastria, if the number of cycles are greater than 3.7 up to 10 cycles per minute. And that could also be bradygastria of around 0.5 to 2.5 cycles per minute. So it's important to note here that tachygastria doesn't necessarily translate to a mechanical advantage in the sense that stomach moves faster and it gets emptied faster. It's similar to a patient having an atrial fibrillation. The heart rate is very fast, but still the cardiac output can be quite low. So it's not exactly a electrical activity which is getting transmitted to a mechanical activity over here. So this is an example of a normal EGG. Here you have the cycles ranging from 2.5 to 3.75. Here you have a tachygastria where you have a increased migratory motor complexes which are getting transmitted over here. So coming now to the management of diabetic gastroparesis. So we have a few subdivisions over here. First and foremost would be to have an adequate glycemic control. Then we have the dietary modifications which should be in place, pharmacotherapy, endoscopic management, and we do have surgical management as a management of last resort. We'll discuss each aspect one by one. Coming to the glycemic management, adequate glycemic control is of prime importance. One caveat here is that we have to beware of postprandial hypoglycemia. So this again, we've already discussed that there is delayed intestinal entry of chyme, resulting in insulin glucose mismatch, and because of which preprandial insulin sometimes have to be given postprandially to accommodate for the delayed gastric emptying. Using an insulin pump or using continuous glucose monitoring does help in preventing hyper or hypoglycemic events. GLP-1 receptor agonists, they delay gastric emptying and can predispose to hypoglycemia again, especially when combined with insulin. One important factor is that the American Association of Anesthesiologists recommends that all GLP-1 receptor agonists have to be stopped at least 7 days, that is a week before a patient undergoes endoscopy, because if there's going to be gastric stasis, then there's a high chance of patient aspirating during endoscopy. So these drugs have to be stopped at least for 7 days before the patient is doing even a regular endoscopy. Coming to the diet. So how does the diet need to be modified in patients suspected to have gastroparesis? So if you plot a chart with the amount of liquids or solids which are getting retained in the stomach along the y-axis, and the time it takes to for the liquid or the solid gastric contents to get emptied, how does it stack up when it comes to different types of liquids or solids that the patient is taking? So the first is the water of 5% glucose. It's almost the emptying starts immediately after the patient, after the person is ingesting the water of 5% glucose. Next comes low-calorie liquids like milk. Next, we can have high-calorie liquids or homogenized solids. Next, they come fairly towards the right. Low-fat solid meal comes next. That is slightly more delayed. Then comes low-fat solids in patients with gastroparesis. Then comes high-fat solid meal in health. Here again, you can see that even if it is going to be a high-fat solid meal, it is getting emptied before 4 hours. And finally, the one which takes the longest amount of time would be a high-fat solid meal in a patient with gastroparesis. So based on this graph is how the diet is going to be modified in patients with diabetic gastroparesis. So avoid high-fat diet, because we know that fat is the one which is going to delay the gastric emptying. And avoid high fiber. We know that MMC, that is the migratory motor complexes, are affected because of the injury to the interstitial cells of Cajal. And because these are affected, we don't have much of the migratory motor complexes which happens during the resting state, because of which there's a high chance of retention of undigested fibrous material, resulting in a risk of bezovas forming. More calories as liquids and purees than solids, because solids take a longer time to empty than liquids. And then the ingested solids should be those that fragment readily into smaller particles, because the trituration or the milling of the stomach is likely to be impaired. Small and frequent meals are recommended, protein supplementation, and in severe cases, post-pyloric enteral tube feeding, or in more severe cases, surgical management in the form of feeding enterostomy may be indicated. Coming to the next aspect of pharmacotherapy, we have a list of drugs, prokinetic drugs, which can help us in treating patients with diabetic gastroparesis. And one important thing to note is that those drugs which have a D2 antagonistic effect can result in hyperprolactinemia, and those drugs which can cross the blood-brain barrier, like metoclopramide, can present with side effects like tardive dyskinesia. Most of the newer drugs like mosapride, etopride, cinetopride, or acotamide, they have a fairly better safety profile and can be given in the longer duration of time. So coming to the invasive interventions, this again can be classified into pyloric interventions, or we can have interventions which can stimulate the gastric electrical activity. Pyloric interventions can be surgical, which is the forerunner of all the endoscopic type of managements, which is the surgical pyloromyotomy. And then we can have endoscopic management in the form of endoscopic pyloric balloon dilatation, botulinum injection, as well as the newer latest third space procedure, which is the G-gastric peroral endoscopic pyloromyotomy. Coming to electrical stimulation, we can have the gastric electrical stimulation or the gastric pacing, similar to what we have as a cardiac pacemakers. So pyloric intervention, baseline is that you're trying to make the pylorus, which is a competent organ, into an incompetent valve. So similar to what you do in a valvuloplasty, again, bringing in the cardiology comparison over here. So to start with, we had the surgical pyloromyotomy, which is the Heineke-Mikulicz procedure. Here, a longitudinal incision is made across all the layers across the pylorus, cutting the circular muscles as well. And once the circular muscles are cut, then the defect is closed in a transverse direction, and an omental flap is placed over the site of the incision for added safety. Of course, we have laparoscopic modifications of the Heineke-Mikulicz procedure. And also in more drastic cases, we can have the patient undergoing a sleeve gastrectomy or even a feeding enterostomy if the case is very severe. Coming to the endoscopic aspects when it comes to treating patients with diabetic gastroparesis, one trial therapy that we could do is a botulinum injection of the pylorus. So what you do is that we take botulinum A toxin, and 4-quadrant injections are made around the pylorus. So 4-quadrant injections are made around the pylorus, making it incompetent. One thing to note is that this is going to be a very temporary procedure lasting for just 3 to 6 months. But what it does is that it serves as a trial, because if the patient is going to respond symptomatically to a botulinum injection, these patients are likely to respond better to more permanent procedures like the GPOM or the surgical pyloromyotomy. So next is the pyloric balloon dilatation. Here you pass in through the scope balloon across the pylorus, and then you inflate it for up to 20 millimeters, and the inflation time is around 2 minutes. And what you're essentially doing is that you're trying to rupture the pyloric circular muscles by having a prolonged wide dilatation, resulting in incompetency of the pyloric valve. Now, the third or the latest procedure is the G-gastric peroral endoscopic pyloromyotomy. This again is an endoscopic means to destroy the pyloric sphincter. So how it is done is that you make a submucosal injection in the antrum, and you raise a large bleb, and then you cut open the bleb and you go between the layers of the stomach. And once you reach the pyloric sphincter, then you cut the pyloric sphincter, making it incompetent, and after which the defect is closed using a hemoclip. This latest procedure, the meta-analysis have reported a pooled success rate ranging from 71 to 82% after GPOM. So coming to the next aspect, which is the gastric electrical stimulation, or otherwise called as the gastric pacing. So this is not a new procedure. It was tried way back in 1963, wherein a post-operative ileus was treated by placing an electrode at the tip of a Ryle's tube and connecting it to an external pacemaker. And this has been later modified. We have the latest Entra-2 system. Of course, it's yet to be available in India. So it is used as a treatment of last resort for patients having drug-refractory gastroparesis. And reports have been fairly good, nearly 80% reduction in nausea and vomiting. One thing to remember is that patients who have bloating or pain as a predominant symptom, they respond less well to gastric electrical stimulation. So this is the system. Here you have the pulse generator, and here you have the wires, and here you have the tip of the wire, which has to be implanted within the gastric musculature. So here you have the programming system based on which the frequency and the voltage of the pulse generator can be adjusted. So what is used is a high frequency, short duration, low energy pulses. And if you're using this, the battery lifespan is nearly 5 to 10 years. So it's more or less a permanent procedure, after which the procedure has to be repeated, where the pulse generator has to be changed. So a small pouch is made in the abdominal wall, which holds the pulse generator. And here you have the wires, which are implanted into the gastric body, that is distal gastric body, around 10 centimeter from the pylorus. And the electrodes are placed 1 centimeter apart. So this is a picture where we have the implantation of the leads into the gastric antrum. And here you have it being covered by a nomental flap. Complication rates are because of the tangling of the wires, and very often 7 to 10% of patients can have infection of the subcutaneous pocket. So we have a list of interventions. We have the diet, then we have the drugs, then we have the surgical interventions, then we have the endoscopic interventions. So which to be used in which sort of a patient is what is very important for us to know. It really depends on what category the patient falls under, and which category is again based on the EGG and the gastric emptying scintigraphy test results. Based on these two, they are classified into category 1, category 2, and category 3 and category 4. So if the EGG is abnormal and GES, that is GES is the scintigraphy, both are abnormal, that indicates severe myoelectrical contractile disorder. So in these patients, apart from diet modification and prokinetics, gastric electrical stimulation would be helpful. Pyloric interventions also would be helpful. And certain patients who are only partially responding, a combination of these two can also be tried as a last resort. Coming to category 2, here EGG is normal. That is, there's no problem with the electrical activity, but the emptying scintigraphy is abnormal. So this indicates pylorospasm, or there's a dissociation between the electrical activity and the pyloric relaxation. For these patients, pyloric interventions would be helpful. Coming to category 3, that is EGG is abnormal, whereas the emptying scintigraphy is normal. In these patients, because it is going to be a predominantly gastric myoelectrical disorder, gastric pacing would be helpful. And we have the 4th category where both are normal. These are not patients with the typical gastroparesis. These are patients with functional dyspepsia who are presenting with visceral hypersensitivity and probably have non-gastric causes as well. These patients do not respond to any of these therapies. They require visceral sensory modulators like tricyclic antidepressants or SSRIs. So coming to the next part of my discussion, this is diabetic enteropathy. Again, diabetic enteropathy would be can present as diarrhea, constipation, or with or without fecal incontinence. Of course, we'll be discussing only about diabetic diarrhea over here. So it's quite common, nearly occurring in 20% of the diabetics. The risk factors, again, are quite similar to diabetic gastroparesis. Poorly controlled diabetes mellitus, coexisting peripheral or autonomic neuropathy is an additional risk factor. Symptoms, usually it is a large volume, painless diarrhea. And very often when we think of nocturnal diarrhea, we think of organic causes. This, again, patients with diabetic diarrhea can have nocturnal diarrhea. It can or may not be associated with fecal incontinence. And the diagnosis, there is no straightforward test. The diagnosis is essentially a diagnosis of exclusion. So we have to exclude all the secondary causes which can present as chronic diarrhea. So other associated causes, that is, which are very much common in patients with diabetics. First is the anti-diabetic drugs. Metformin, it again has a multiple mechanisms by which it can present as diarrhea. It can alter the gut microbiome. It also increases the intestinal glucose. It reduces bile acid reabsorption. It also increases GLP-1 concentration. So by all these mechanisms, it can impair absorption. It can reduce intestinal motility, resulting in SIBO, as well as because of the increased bile acid reabsorption, it can present as a kind of a secretory diarrhea. And we can have the alpha glucosidase inhibitors, which can present as an osmotic diarrhea. GLP-1 receptors, again, have multiple mechanisms by which they can produce diarrhea. Second common associated cause would be a pancreatic insufficiency, because we know that pancreatitis is nearly 2 to 4 times more common in diabetics. Clostridium difficile infection is an independent risk factor in patients who are diabetics. Celiac disease, especially in patients who have a type 1 diabetes mellitus, they have a 5 to 10-fold higher prevalence. And of course, we should never forget the sugar substitutes, because most of the sugar substitutes are poorly absorbed sugars, which can present as an osmotic form of diarrhea. So ruling out other causes, first is a small intestinal bacterial overgrowth. Glucose hydrogen breath test would be helpful, but a more straightforward way of treating it or using a treatment and assessing the response would be to respond to antibiotics. Rifaximin, 550 milligram 3 times a day, given for around 10 to 14 days would be helpful. Celiac flu, especially in type 1 diabetes mellitus, diurnal biopsy, anti-TTG, anti-glucogliadin antibodies also will be positive, and there will be a proper response to gluten-free diet. Coming to bile acid diarrhea, this is a watery diarrhea, and patients usually respond to cholestyramine. Anorectal dysfunction, patients present with incontinence and anorectal manometry would be diagnostic. Lactose intolerance is fairly also common. So lactose hydrogen breath test and response to lactose-free diet, again, would be a pointer towards lactose intolerance. Iatrogenic, never forget the drugs that the patient is taking, and response is usually within a week or two after withdrawal of the drug. And IBD, of course, fecal calprotectin will be elevated. Endoscopic and biopsy would be helpful. Coming to the management, an algorithmic management would be most essential. Suspected enteropathy, clinical evaluation, duration, stool characteristics, and presence of autonomic neuropathy has to be looked into. Exclude alternative diagnosis because diabetic diarrhea is essentially a diagnosis of exclusion. Rule out celiac, lactose intolerance, drug-induced diarrhea, exocrine pancreatic insufficiency, and IBD. Confirm this if everything else is ruled out. Diabetic enteropathy is how it is confirmed. A stepwise therapeutic approach would be to ensure hydration, antidiarrheals, because it's essentially going to be a symptomatic management on treating the cause. And most of the patients do respond to an improved glycemic control. Empirical antibiotics, because the way most of the mechanisms act is that it impairs intestinal motility. Because of impairment of intestinal motility, there is secondary SIBO, and SIBO is the one which is most often causing diarrhea. So rifaximin, a trial of rifaximin will be helpful. And patients who are refractory to usual treatment, somatostatin analogs, they delay the intestinal motility, so they can be tried. And if pain is predominant, add a tricyclic antidepressant as well. So to conclude, GI manifestations in diabetes mellitus are common but often under-recognized and under-treated. Pathophysiology is multifactorial. Autonomic neuropathy, disordered motility, impaired immunity, and coexisting offending drugs are most often implicated. Exclude secondary causes. A systemic stepwise approach is most essential. A good glycemic control is essential because there is evidence to suggest that early in the course of the disease, diabetic gastroparesis as well as diabetic enteropathy can be reversed. Treatment is multidisciplinary, involve the dietitian, diabetologist, gastroenterologist, and of course, surgeons do come in when when the patients are quite refractory to the usual treatment. So, well, thank you very much. It'll be good to have some discussion or questions around.
Thank you, Raja. That was a wonderful talk.
Thank you.
Very informative and elucidative. Your slides were far out. And even though you had focused only on gastroparesis and enteropathy, I think you almost covered the entire GI manifestations of diabetes mellitus and also the management. It was very excellent.
Thank you, sir.
Now, I hand over the mic to Dr. Chandrasekhar.
I think I must appreciate Dr. Raju again, despite the heavy work in the unit, you could manage to find some time to prepare the talk. And both the talks have been extraordinary. And Professor Joshi, with his the several decades of experience and the wisdom, he summarized. He can talk for diabetic for 3 days also, but he had to do it in 30 minutes. So actually, I always remember Winston Churchill was asked to give a talk. So he said, okay, I'll give you a talk. How many minutes, they asked him. He said, you can give a talk for 2 hours. Then when will you give the date? I will talk to you tomorrow itself. Then suddenly the other person said, no, sir, this talk is for only 1 hour. Then he said, no, then I need 5 days preparation. Then somebody else barged in the room. He said, so your talk is for 30 minutes only. Then you give me 2 weeks time. Then suddenly there is a call from the queen that your talk is only the truncated 10 minutes only. then you give me one month time. So to summarize the diabetes in 30 minutes and GI tract normally it takes time. So I always remember that shorter the time duration you are going, the more preparation you need to do that to prepare. So with this, I will start the first round of questions to the speakers, and moderators will start it from Dr. Lakshmanan and Dr. Ganesh. Lakshmanan, your question to one of the speaker or Dr. Professor Shashank Joshi. What is your comment and question? Then after that, Ganesh. Then we have 3 panelists. Then we'll go for the second round of the question. We have 30 minutes, a good 30 minutes to interact with the hour. So starting with the Dr. Lakshmanan.
Shashank, a question for you. Your
Yeah.
starting drug in a middle-aged diabetic in India, is it a metformin or a SGLT inhibitors or a GLP-1?
As I said, you have to individualize, but the short answer is metformin, unless and it is a compelling indication for a SGLT2 inhibitor or a GLP-1 agent. Even if it's a middle-aged patient, if there's a high cardiovascular risk or multiple comorbidities or a compelling obesity, my standard of care still remains metformin. It's not changed, though the compelling need for SGLT2 or GLP-1 with proven efficacy is available, affordable, accessible. If a person is very morbidly obese, 120 kilograms, maybe a GLP-1 receptor agent might be a reasonable option. If somebody has, cardiorenal issues, which are already there, already undergone, or say, a bypass surgery or something like that, maybe an SGLT and with a compromised ejection fraction of 35, then maybe I would probably look at DAPA or EMPA. So, it will be profiling, but that's how I would look at it. But otherwise, it's a garden variety patient. Probably metformin is still the agent of choice, but I will always do a cardiovascular risk profiling. I will look at the weight and I will look at the CV risk and then cardiorenal risk. I'll also look at the presence and absence of metabolic fatty liver disease and osteohepatitis, as they call it. And based on that, probably, but more and more, Lakshmanan, you will see the encroachment of SGLT2 inhibitors and GLP-1 receptor agents in this space. And you're seeing that already happening because now both DAPA and EMPA are off patent in India. And we also have availability of an oral GLP-1 analog semaglutide. And now we have an injectable tirzepatide available. So you will see this entire scope expanding, but still standard of care still remains metformin.
I think before Dr. Lakshman, Ganesh asked, I have a question to Dr. Joshi.
Sure.
Now hypertension, especially they believe that there's no role for monotherapy. They start with a combination therapy. Do you have such idea that, okay, metformin alone, I will try to the last highest dose, then I will switch over to other drug? Or what is the role for monotherapy and combination therapy in diabetes?
Increasingly, we are going for a primary dual and triple therapy. So if your A1C is between 7.5 and 9%, usually a dual or triple therapy is what we give. In fact, me and Dr. Panika published almost 25 years back in JAPI that, the standard of care is dual or triple therapy. And that's as primary, So we really don't wait for the old WHO approach, metformin max out dose, then add a second agent max out dose, then we straight go to 2 or 3 agents with 50% of the pharmacological dose and initiate. So the dictum is hit hard, hit early. Because in the first decade of a diabetic's life, you are generating a lot of glycemic burden, and that is equal to vascular burden. So if you are getting tight glycemic control in the first decade of a diabetic's life, you will create a metabolic memory. And therefore, dual and triple therapy is evidence-based, logical, and now approved by most guidelines.
I think that's a very important take-home point. Like I recently attended the World Hypertension Congress held in Chennai. They believed that they started doing for the no more monotherapy, go for the combination therapy. So your key is the HbA1c and comorbidity, cardiac, renal, and the obesity point. You put everything into together. And is there any app available where you put it everything, this drug can be chosen?
Well, I think you need to just do a simple algorithm. I think you look at glucose, A1C value. Then the second thing which you look out is is there a presence of heart disease, liver disease, or renal disease like EGFR? then you look at cardiovascular risk profiling,
Yep,
and look
come in.
at BMI of fat. And
Okay.
in these
Nice.
four quadrants, you can easily box it out.
Miss who?
And there is no need for an app because it's individualized treatment. And then initiate a dual or
Don't they
triple.
have it in the front?
Dr. Ganesh, thank you.
Raja,
Dr.
the question to you is, do diabetic patients have increased risk for celiac disease? Can you highlight what is the association between celiac and diabetes?
Yes, celiac disease, especially when it comes to type 1 diabetes mellitus, they have a very close association. They have nearly around 10% increased risk of having celiac disease when it comes to type 1 diabetes mellitus. Not so strong association with type 2 diabetes mellitus. And that stems from the fact that both type 1 diabetes mellitus and the celiac disease, they almost have a similar HLA risk. Both have HLA2, DQ2 and DQ8. Both are quite common in both type 1 diabetes mellitus and patients with celiac disease. So that's when the risk association is happening. So that is fairly common in type 1 diabetes mellitus.
As a corollary, can you just tell us, because we know celiac disease is due to gluten hypersensitivity, but what about diabetes type 1? Do you have any reason to say that it can also be due to gluten environmental cause, which is again adding on to the risk?
Not environmental. I think it is all stems from the fact that there is some sort of an immune dysregulation in type 1 diabetes mellitus. That type 1 immune dysregulation is directed towards the islets of pancreas, and dysregulated immunity is directed towards the gluten. So that's when the common thread lies between type 1 diabetes mellitus and celiac disease. It's more of a dysregulated immunity rather than an environmental factor.
Okay, thank you. Dr. Sitaram from Nepal, you have a question to Dr. Joshi. Yes.
Great talk, sir. Great talk. As you said, in half an hour, Dr. Sasank, sir, taught us so much. So that was really great. And also, Dr. Raja also told us about particularly the gastroparesis and the diarrhea. So Dr. Raja told so much of detail of these two things. So I was realizing that we need to know details of maybe everything. So that was very nice. One question I'd like to ask Dr. Sasank is about these weight reducing drugs. So how much that is in practice, the weight reducing drugs, and how much that is cost effective? Semaglutide for Dr. Sasank.
So Dr. Sitaram, that's a great question. I think both the drugs, in oral semaglutide and injectable tirzepatide, are now available in India. Tirzepatide is just available for last 1 month. Start low and go slow, because they do cause a lot of nausea, vomiting, and GI side effects. So you have to go with the lowest possible dose. They are effective, they are impactful, and they reduce complications. So and they reduce complications across board. So I think both semaglutide orally, you need to give it first thing in the morning on empty stomach, wait for 60 minutes, and then give the drug. The Mounjaro or the tirzepatide you have to give once a week. And we are going to get other agents coming up. I'm sure in Bangladesh already there are these agents available generic, because you don't are covered by patent law. But both these drugs need a slow titration, a very slow titration and education. And occasionally they need they get discontinued, but most of them are safe. Two concerns. Number one is somebody has history of pancreatitis, they go out. If there's history of thyroid malignancy, they go out. And if there are many a times there is biliary sludge, gallstones, they do predispose and predict people who are with obesity, them to develop pancreatitis. So from a GI standpoint, I think that's one red flag. So you need to be a little cautious and careful, because these other end of the spectrum of pancreatitis. So you need to be a little mindful that these agents are very powerful agents, and they cause anti-craving effect. They cause a lot of GI adverse events, and very rarely and occasionally they can cause pancreatitis in a scenario if there are more than 2 risk factors for acute pancreatitis.
Okay,
great, sir. And a little bit, can you tell us about the endoscopic treatment for diabetes, if any, in practice, real practice? Type 2 diabetes.
Endoscopic treatment is more for obesity, and there There are gastric balloons. There are endobariatric procedures. Endobariatrics is a subject by itself, and you can have a complete class on
Little bit, just
I think,
little bit about
Sitaram,
that.
that is
Okay,
the
okay,
you
okay.
can actually, you can
Okay.
impact weight loss. Basically, this is like an endoscopic sleeve. So what you are doing through surgery, you are doing through endoscopy. So it's like interventional gastroenterology, and it is being done in some state of the art centers. I'm sure Dr. Chandrasekhar Center may be doing it. I know for sure AIG does it, and many other centers in India do it. But it's still work in progress. So,
Thank you, sir. Thank you.
Dr.
Thank you so much.
Sitaram, we are going to have a separate session on metabolic endotherapy.
Okay.
So
Thank
in
you, sir.
June, and
Okay, it's okay, sir.
Dr. Farooq Ahmad, your
Thank
question
you.
to speakers.
Huh?
Dr. Farooq, yeah.
Sorry.
You are audible.
Please repeat, sir.
Yeah. Your question to Dr. Joshi or Dr. Yogesh?
I can ask a question to Dr. Raja because I am gastroenterologist.
Okay.
So, regarding gastric electrical stimulation, I want to know from you whether it is available in India, and if it is available in India, how do you select patients to do this procedure? And what is your experience in India regarding the efficacy of this electrical stimulation for gastroparesis due to diabetes?
Sorry, sir. Unfortunately, it is not available in India as a yet. But there are chances that Medtronics already has a lot of market in India. They've come up with the other implantable devices, but it might be available in the future. So directly, I don't have experience in treating patients with gastric electrical stimulation. But the way you choose the patient is based on these two results. That is, the patient should have an impaired gastric electrical stimulation. That is, when you do an electrogastrography, there should be either a bradygastria or tachygastria, which results in a gastroparesis. So only patients who do have gastroparesis symptoms and have an abnormal EGG would benefit from this intervention. And again, this is not a primary intervention. This should be a treatment of last resort. That is, the patient doesn't respond to diet, doesn't respond to the usual prokinetics, doesn't respond to pyloromyotomy if that is also coexistent, then this comes as a fourth or the last resort when it comes to treating diabetic gastroparesis.
Thank you.
And my second question to you is, what is the prospect of this therapy in India? Because India and Bangladesh scenario is almost similar. In Bangladesh, there are a lot of people suffering from diabetes. But as a gastroenterologist, we got a lot of patients with upper GI symptoms, especially in diabetic people. But unfortunately, we could not confirm whether it is gastroparesis or something else because we don't have all these investigations available in Bangladesh. So I think in spite of this, the scenario is same as in India. So what do you think about the prospect of this electrical therapy to relieve gastroparesis, especially in diabetic patients?
I think we do come across patients occasionally who are refractory to the usual prokinetics. The way to go about is to investigate properly, make sure it's not just the functional dyspepsia that you're dealing with over here. So first is the endoscopy. As we discussed, there has to be some retention even after 12 hours of fasting. That gives us a clue that there is diabetic gastroparesis. Rule out any organic cause, rule out metabolic causes like hypothyroidism. And then the primary gold standard test would be the gastric scintigraphy. That is available everywhere, that I'm very sure. And if it is showing a positive result, then a gastric pyloric intervention, again, can be tried because that is fairly easier and the patients do respond to pyloric, either botulinum injection or a balloon pyloroplasty. If it is showing a limited response, again, the patient is having another recurrence of symptoms which are again refractory to the usual therapy. That is when you think of a gastric electrical stimulation. Once it is available, then I would be able to tell my own experience on that, sir. But as
for us, the problem is that we don't have.
May be available in the near future.
Dr. Farooq, the simplest is that I just want to re-emphasize what Dr. Yogesh said. When you call the patient for upper GI endoscopy after 12 hours of fasting, if you see the lot of gastric retention in the food is the previous day food is there, then it is gastroparesis. You have to, and you rule out the secondary causes, then you have to go ahead with that. Now, Dr. Akande from Nigeria, You are sitting on a beach and enjoying the breeze, or it's an artificial backdrop? A second day. I was
Yes,
surprised with your incidence of diabetes in Nigeria. And I don't know whether what is Dr. Joshi's reaction to that? Diabetes is so low in Nigeria.
yeah, not that low. It used to be around 2.2%, but recently it's coming to 7%, 10%, more in the southern part of the country. But it used to be low, but now it's coming up. In fact, IDF will say it's about 3.7%, but the meta-analysis recently put it between 7 and 10%. So relative to India, is still low, but it's coming up because of obesity and other sedentary lifestyle.
So what is your question to Dr. Joshi and Yogesh, or comment?
Yes, well, very lucid lectures. I've gained a lot. Just to find out that when you have a suspected gastroparesis, and in Nigeria we have scintigraphy, but it's not that commonly available. We don't have other form. What was the role of this functional ultrasound? How useful is it in the diagnosis of gastroparesis, especially diabetic gastroparesis? Over.
Yeah, Dr. Joshi, you'll be seeing a lot of every day hundreds of diabetic. So what kind of GI problem? You have a data, okay, these are the common problem. First is I see, what is your data about GI problem and diabetes?
I think they are rampant. And I think I'm a tertiary care practitioner. So, every third patient on an average will have some GI disturbance. It could be as simple as a hyperacidic state, a GRD, a reflux, diarrhea, autonomic dysfunction. So pretty much everything we see. So it's because we see the entire end spectrum disease, and we see a lot of tertiary care referral work. So we see everything. And I think what's pandemic with syndrome the con with type 2 diabetes is the MFLD. I just had installed a fibroscan machine in my clinic, and I screened virtually out of 10 people who were living with type 2 diabetes, 8 of them were having MFLD. So it's pretty high in the Indian population. And I think that's the way we eat. We eat a lot of carbs and fats and very less proteins. But I think what Dr. Raja said, we do see a lot of bad gastroparesis, and often it gets misdiagnosed. And as endocrinologists or diabetologists, we should look at the gut a little more seriously. It's like we often dismiss it off and just put them on a PPI or a prokinetic agent. But I think it needs sometimes a thorough evaluation. And I think it's important to recognize both liver and gut need a thorough evaluation in the Indian population. Just one comment about polyglandular immune syndromes. So type 1 diabetes, celiac disease, autoimmune hypothyroidism, they are all affiliated in this entire type 1, type 2 polyglandular autoimmune syndrome. So they are grouped. There are associations which are very well documented. They are organ-specific autoimmune diseases, and we need to be mindful that we need to screen for each other.
We'll go to the second round of now. We started Dr. Lakshmanan. This second round will be faster, quicker.
Dr.
Okay. Yes.
Dr. Chandrasekhar, sir, I have one question.
Arvind, okay.
Yes,
you please. I see the hands raising. Okay, Arvind, please, your question.
Yes, I have one very important question for to the eminent speakers. My name is Dr. Arvind Kubi. I am an ambassador from Karnataka region. I'm from Bengaluru. For the last 2 weeks, I've been getting inquiries from the young girls who are about to get married, because they're all aware about this new drug, which has come as an injectable form, Monjaro. All right, and for them to attain a good weight loss, right? Don't you think going forward, this drug will definitely be abused, misused, and overused by majority of the physicians and also the local practitioners, sir?
It is already abused by lay people, because people are coming to ask for it. You are absolutely right, Dr. Arvind. And therefore,
don't you think that there should be
So actually, initially the DCGI had only said that this drug should be prescribed by
regulatory for an absolute.
So the drug was approved by the DCGI to be prescribed by endocrinologists. But now they have said endocrinologists and physicians. it needs scrutiny and supervision. But weight loss is a disease and needs medical supervision. You're absolutely right that we need to ensure that it is appropriately given to the indicated cases.
Arvind, nowadays you can see all the senior actresses who become suddenly slim.
Absolutely.
Most of them have
Absolutely. In fact,
they got the medicine from
my
Dubai
That's
or
true.
Bangladesh, and they reduce almost 20 to 25 kg. I have an actress in my list. She demanded the drug to be used, but the approved indication is only type 2 diabetes with obesity. Type 2 diabetes with obesity. Off-label use is patients with obesity. I think when you use
I have 3 senior artists from Canada who is talking to me almost on a daily basis for me to use this drug. But there should be some absolute indication. I've been trying to convince her. So they are not getting convinced at all. They say that when Karan Johar is being used using semaglutide, why can't I use Manjaro?
So Dr. Arvind, two things. One is if they have compelling need for losing fat, and if they have documented extra fat mass, you may have a compelling indication, but tell them that they will lose muscle mass and they will also aged. So if you see many of these people, when you lose weight, you lose fat and muscle mass both. And the muscle to fat ratio can be adverse, number one. Number two, I think eventually if you don't give, somebody else will give.
Yes.
So they need supervision. They need 3 screens. Number one, mental health screen. Screen them out for any mental health disorders, including suicide. Number two, they need oncovigilance, because if there's a thyroid cancer history or thyroid disease history, they are out. And number three, they definitely need to be screened for muscle mass. So it's important to recognize that when you're screening these people, you need to give them some education. You need to dispel their myths. You need to tell them that these are agents which are wonder drugs, but they're strong drugs with adverse events, and they are not to be used off-label. They have to be used under medical indications. Type 2 diabetes is a compelling indication. Unfortunately or fortunately, now obesity is also an indication. So it's important to recognize that because obesity is an indication and obesity is now recognized as a disease, probably there will be more and more compelling indications coming to it. And these agents actually have data to show that the pre-diabetes to diabetes comes down. So I think profiling them, doing their blood work, doing their LFTs with amylase lipases, doing their sonographies, doing their fasting glucose insulin ratios may be relevant and important.
I think your point well taken, Dr.
Excellent inputs.
Yeah, what they do is they don't even consult any doctor in India. They procure the medicine from abroad. Then they have halfway through they have already taken the medicine. Is it safe, doctor? They're coming and asking. So any number of, I only tell them you not only lose fat, you lose muscle. You may look older also. Then they are perturbed. Sometimes suddenly you lose all the fat and the muscle. The charm will not be there. So I used to tell them that you have to be very careful. Anyway, we'll go to the other.
Shashank,
any other ambassadors you want to ask questions, Dr.
Shashank, I have a question for you.
Yeah.
Can you elaborate something on the triglyceride glucose index or the ratio? Because of the common crowd way we have a high triglycerides in our population.
So triglyceride is equal to the carbs we eat. So and basically, it's not having an odds ratio for a cardiovascular risk factor. But we know one fact, very simple fact, fun fact. When the triglycerides go up, the LDL particles become small and dense and sticky. When the triglycerides come down, the LDL particles become large and fluffy. So it's important to recognize that in the small, dense, oxidized LDL, the elevation of triglycerides is important. And triglycerides directly are proportional to the simple glucose. And therefore, the type of foods which we are eating are all ultra-processed foods. And there's a term called HFSS, high fat, sugar, and salt. And that is and particularly processed or ultra-processed foods. And people are now ordering food from outside with various apps. And that is something which needs to be discouraged. That is the one which is causing the obesity and diabetes. So you are absolutely right when you ask this question. I hope I have answered your question.
Okay. Any ambassadors question, Rajiv and Praveen Kumar? And you have any question to both the speakers or moderators?
Sir, I'm Dr. Praveen from Kerala, sir. I have a question to Dr. Shashank, sir. Suppose a middle-aged lady comes with diabetes in the form of FBS around 200 and PPVS around 300 with a very high hemoglobin A1C. Which is the initial drug of choice of your experience, sir?
Can you repeat your question?
That is a middle-aged lady coming with a very high hemoglobin A1C, newly detected diabetes.
If she has family history of diabetes, she's type 2. If she's type 2, probably 2 or 3 drugs will be in order. So they will usually go on a metformin, gliptin with or without SGLT2 inhibitors. That's going to be the order of the day. If the obesity is overwhelming, she's 200 kilograms, I may look at a GLP-1. But if she's 50 kilograms, I will not look at a GLP-1. So usually the standard of care is a gliptin, metformin with or without SGLT2 inhibitors. That's how one would approach in this particular case. All these 3 drugs are generic. They are freely available, they are economical, they are affordable. For SGLT2 inhibitors, you will need education. That's all. So for a middle-aged lady, that would be my treatment of choice.
Okay.
Okay. Any Dr. Nirmal, you are there? And Dr.
Yes.
Chandramouli. Yes, Nirmal, what is your question?
No, sir, I think 2 real wonderful piece of talks from Dr. Shashank as well as Dr. Raja. So, sir, how now we are seeing, even in Punjab, I belong to Northern India. So there is almost an epidemic of metabolic syndrome and fatty liver disease, and diabetes is part of our daily treatment, what we see in liver disease. So people with chronic liver disease, maybe a compensated, obese and diabetic, what will be your first choice with associated, I told you, compensated liver disease, diabetes, and say BMI of 30, coming for the first time? So what prescription you are going to give to this patient, Dr. Shashank?
You have 3 options here. It's a very good question. Number 1, here is one place where you can use a GLP-1 receptor agent, either semaglutide or tirzepatide. It will work here. There's data worldwide available on it. Here again, there is data on both DAPA and EMPA which may work here. There is also data for PIO here. So probably you will have a backbone of metformin with either a PIO and or a GLP-1 and or a SGLT2 inhibitor, and you can take a call here. All these 3 drugs will be better. But one thing is there that GLP-1 receptor agents in this space will become a standard of care. Currently, they may not have approvals in place. But, the ones which have documented data in meta-analysis are vitamin E and pioglitazone. But I think beyond vitamin E and pioglitazone, you will clearly see a DAPA-EMPA coming there, and you will clearly see GLP-1 receptor agent, semaglutide, as well as tirzepatide coming there. So I think you have those choices. So from in my hierarchy of choice, it will be tirzepatide, semaglutide, pioglitazone, metformin, DAPA-EMPA.
Shashank, the saroglitazar is being promoted to all gastroenterologists for fatty liver.
Saroglitazar is a very good compound for fatty liver disease. It has generated a lot of India data. It is a dual agent. It's a PPAR gamma and alpha agent. It is very good for triglyceride reduction. It's a very good anti-diabetic drug also, and it has documented good data on remission. But most data is in the F2, F3 space, and anti-fibrotic data on biopsy needs to be documented. They are undergoing phase 2 clinical trial program in the US in a rare disease indication of primary biliary cirrhosis. So we'll see that data, how it comes out. It is an agent which is a local agent available with local data. And I use it also in appropriate cases. I am not, and in the diabetic metabolic space, it does have a role.
Dr. Girish, you have a question? Dr. Girish, so there is a question from a delegate. How do you switch over the patient from insulin to OHA? So what is your take, Dr. Joshi?
So
and the patient is on insulin, you want to switch over?
First thing is do a C-peptide. If C-peptide is low, then you cannot switch the patient from insulin to OHA. If C-peptide is normal or high, and the total units of insulin is more than 40 or 80, you might at best be able to halve the dose and optimize weight loss with an agent like a SGLT2 inhibitor or a GLP-1 receptor agent. If the number of total dose of insulin is 20 or 40, it may be easier to switch. So usually we use 2 or 3 agents, but it is not a must that every patient, it depends on the merit and the indication for which insulin was started in the first place.
Okay.
If the insulin was started for an acute emergency, it is easier to take it off. If insulin was started because there was no C-peptide on board, then probably you need to continue that insulin. Remember, insulin is more than 100 years old. It is the first anti-diabetic agent on planet Earth. It is anabolic, it improves appetite, and sometimes can also be combined with a GLP-1 receptor agent. In fact, in India, there's a combination where we give insulin and a GLP-1 receptor agent simultaneously. And insulin will control the fasting blood glucose, and the short-acting GLP-1 receptor agent will control the prandial blood glucose. So that also can be combined. The weight loss or effect of GLP-1 and the no hypoglycemia effect of GLP-1 can be mitigated. So they can also work synergistically together.
So I think the key is the C-peptide evaluation, and accordingly. Another delegate has asked, what is the difference between on what basis that to differentiate MODY and the type 2 diabetes mellitus? MODY, I am telling.
MOD is rare, usually seen in South India. 3 successive generations. Grandfather, more than 60, got diabetes. Father got diabetes at 40. And the index case is getting diabetes at 20. That means 3 successive generations. Usually skipped a generation each. Age of diagnosis less than 25. Autosomal dominant. Adequate C-peptide on board. High suspicion for MODY. Send them to an ICMR genomic center like Dr. Mohan Center for genomic testing, or to a private lab. If the gene is positive, this is MODY. It's rare, it's monogenic, and it's seen, but it's autosomal dominant, 3 successive generation. The index case has to be less than 25 years.
Chandrasekhar, can I narrate a small, my patient on MODY?
But there's only 1 minute left. After that,
Okay,
10
fine.
minutes
Okay,
to
fine.
know about that. One question from the delegate, where G poem is contraindicated to Yogesh?
G poem contraindications would be any similar contraindication to any submucosal or third space procedure that includes uncontrolled coagulopathy, patients having high cardiopulmonary risk, and patients on anticoagulation. Those would be the standard risk. But there would be certain cases where G poem might not be effective. For example,
He wanted it may not be effective. Yeah.
Okay. Okay. May not be effective would be patients who have a fibrosed pylorus wherein there is no mechanical contraction because of the muscle. It is more of a fibrosis, which is resulting in a fixed state of the pylorus. So these patients do benefit from doing the flip, where you do a functional luminal imaging probe, where you know the distensibility of the pylorus.
Okay.
So those patients.
Dr. Girish and Dr. Chandramouli, you have any question? Before we wind up, there are 2 speakers, very clear, very thought-provoking talk, and there's so much to discuss about the poem and the diabetes and the GI tract, and we just got kind of inspired to go and read more about the diabetes. Diabetes is not as simple as what we used to manage, either insulin or metformin. When we started our career in the early 70 and 80, now so much data available, and diabetes has become so common in India. Every specialist should know something about, because the moment you see patient, you have to have 10 drugs are available. 3 drugs are the diabetes, 3 for the hypertension, 2 for the hyperlipidemia. Then only your drug comes, your specialty drug. So I think that the main idea of having the whole series of webinars, 12 webinars, one general topic, one GI topic, we have made it. I think Dr. Justice Ang made a wonderful, the thoughtful, the preparation of the talk, which is tailor-made for gastroenterologists and the other specialties. And Yogesh did a fantastic job in summarizing. Even though we do see sometimes the fungal infection of the esophagus, motility disorders of the esophagus, and sometimes very disturbing constipation also in diabetic. Now I take time to know more about the other aspects of our faculty. So this is in the lighter sense. This will be we'll have a kind of short questions and the brief answer. I will start with Dr. Shashank. So who is an inspiring personality in your life? It's nothing to do with the diabetes or gastroenterology now. It's totally, this is how our delegates also get inspired from.
Inspiring personality, Chanakya.
Oh, Chanakya, that is historical. In your when you got into medicine and other thing, Chanakya is very good. I mean, because he is full of wisdom and he is very diplomatic and he is very success oriented. I think you have all the combination traits for you also.
Chanakya, you want in real life, you mean to say?
In real life.
I mean, my mentors. In fact, one of my mentors was a gastroenterologist. He's still active. not in practice now, but he's retired, Dr. Sharad Shah.
Oh, Sarasha.
And
He was a pioneer in the field of gastroenterology in western part of India.
he was my teacher, so
Oh,
I owe a lot to him.
and very hardworking, very smart way of working also. So he was your inspiring person. What is the non-medical book you have recently read?
I read Bhagavad Gita, and I'm still learning Bhagavad Gita. So
And
that's
then,
the last book which I think is relevant. And I'm writing a book called Ancient Code on Atharva Veda.
oh, that is very good. So you have read that, listen. So how do you manage work-life balance?
That's a tough question. I think you have to draw Lakshman Rekha. And I think it's important that we sleep for 6 to 7 hours, which I do. And we need to ensure that we need to do the me time. Doctors are bad patients. So we need to draw a line and ensure that we take care of ourselves. And I think doing a little bit of meditation, exercise, and mindfulness helps.
But I asked for work-life balance. I mean, how do you spend time with the family? And
So as I said, I work 5 days a week. I don't work on weekends. And I don't work more than 10 to 12 hours. At a point of my life, I did go through a physician burnout. And I think it's important to restrict because if you don't draw the line and you don't spend, and have meals with your family members and near and dear ones, you will not be able to achieve. So I actually stay from my workplace. I have breakfast, lunch, and dinner every day at home. That's
okay, right. That I will come back to with some other interesting one. Lakshman, what is the non-medical book you recently read?
To be frank, nothing.
Okay. And what are your hobbies?
I'm a exercise fanatic. No, I go
You are
to.
a sportsman, no?
I
Look
play
like a military person.
once, and
So,
I'm now 76.
okay, very good.
In a
And
very
you're-
good health.
Thank you.
I keep my muscles intact. Like I don't waste my muscles.
So, what is your exercise schedule, briefly, in 2 seconds?
Morning 40 minutes I work out in the gym, and after evening I walk in a treadmill. And weekly once I play long tennis.
Oh, that is fantastic. I think we should give a big round of thing that doctors only advise, but they don't do that, and you are doing that. Very good. Who is your mentor?
Kalam, Abdul Kalam.
Abdul. No, in your real life, whom you have met more frequently, and
Always my teachers, my chief, Dr. G. Subramaniam,
Ananda Subramanian,
who taught me medicine.
So Yogesh will be a little unhappy if I ask the question, what is the non-medical? Because he is working with me, so I don't give any time. So, yeah, but I want to ask, what is the non-medical book you have read recently?
Yeah, it wouldn't be recent, but the last non-medical book would be a novel, Nicholas Nickleby.
Okay. So he had come prepared because he had to. But when do you get time then?
Most often it used to be an audiobook. So whenever I drive, I
Right.
listen to the
So what
audiobook.
is the famous quotation, Farooq, you like, which is really inspiring quotation to you? The quotes from quote. Okay, I really like that quote.
Sure, that is a quote from this is President APJ Abdul Kalam. When
Okay.
you find a door closed in front of you,
Uh,
you will get a lot of door open for you. So don't leave it up. If you
Can you?
find a door closed
Ah.
for you, hopefully you will have a lot of other doors open for you if you do
So
not
look
leave.
for a good opportunity.
Yeah.
So don't miss it. What is
Yeah.
Akande, your quotation? Dr. Akande? Okay, well, what is the famous quotation inspired you, Dr. Shashank? Which you would like to tell that, okay, this is the quotation, I like it.
I think for doctors, my quotation is very simple. Primum non nocere, which is Latin, which is first of all, do no harm.
Huh?
Primum non nocere, which first of all, do no harm.
Do no harm. That is the one. That is the Hippocrates, the oath, no?
That's
so
right.
what is the quotation? This is the one you like it, huh?
I mean, I write my own quotations. You can read me on Twitter every day or all social media. And I have a WhatsApp channel you can follow. I actually have a library of quotations. So I don't want to,
single out one thing, huh? Okay.
not really. I think because every day is different. So
Ah.
we have to be grateful that we are alive and we are happy.
Okay, you are from Bollywood area. Which is who is your favorite actor and actress? Or you don't see movie at all?
No, I do see movies. So my favorite actor still is Amitabh Bachchan.
Okay.
And favorite actress is Wahida Rehman.
So we all come to that age, I think. So you speak. What is the famous quotation, Dr. Lakshmanan?
In life or in practice?
No, anywhere you can classify like that also. In my life, in my practice, also you can tell that. Okay, we have 2 more minutes to go just to wind up. So this will be interesting to know that. Okay, in life, what is it? In this one, what is it?
I think I follow Tirukkural. Two short lines now that makes you sense
that is
every aspect of your life, I think.
okay. Tirukkural is fantastic. I think those who don't know that, there's a lot of translation available in English and other thing. And one thing, he has got everything to tell for every situation in life. So that is 2000 years old. This one, that is in life. What in practice, what do you think?
Practice, you always go for the patient-centric. We always apply criteria to the patient, affordability of the patient. When you give a
Okay, that is your working pattern, the quote. Okay. Yogesh, what is your famous quotation?
There's one quotation which says, it goes like this: don't judge your day by what you reap, because that is a product of yesterday. Judge your day by what you're sowing today, because that will be the product for tomorrow.
Yeah, what you are yesterday is not important. What today is important. I was so and so, I was this much is not important, but what you are worth today is very important. Like that. Dr. Ganesh, I don't see you. What is your quotation? And Dr. Ganesh, you are hiding.
My quotation is very simple. Be good, do good.
Very simple.
Yeah.
Okay, right.
Very simple.
Who is your favorite actor and actress?
My favorite actor is Amitabh Bachchan. And in South, it is Shivaji Ganesan. I still like that.
You come to that. Actresses?
Actresses, I think the old actresses will be Saroja Devi, I think very expensive. The new one, most of them are the same.
So who is the famous sports personality you like, Lakshmanan?
Allowed to meet Pele. The famous
you like Pele. Like Pope said, he also liked the one who recently passed away. He also said, Pele is my favorite, even though I like Messi and like Maradona also, but my favorite is Pele, he said.
Other one player is Dhyan Chand.
Dhyan Chand.
The great hockey wizard.
Hockey wizard. Who got the Olympic medal for us? No? And last Akande, what is your choice of sports personality and your quotation?
Yeah. My quotation is that part of the Hippocratic Oath that says that I will attend to my own health, well-being, and ability.
Okay. Okay, I think we have come to the end of the webinar. This is the 33rd webinar. We have been organizing international webinar, and delegates from all over the world will be attending this. And I must be very thankful to Dr. Joshi in a short notice. He immediately agreed that even though he was so busy, then he came out and the topic very close to him. He made a fantastic and he get an orientation. Especially I am of the idea that whatever may be your specialty, you should know something about diabetes, something about hypertension, something about dyslipidemia, and what are the drugs being used in the various combinations, and what is the individual treatment, as Dr. Sestong was telling repeatedly, profiling your treatment according to the patient need, what is the comorbidity, what is having renal failure, cardiac, and what kind of modalities you are going to give. That is equally true with the hypertension. Next month, we are going to have the hypertension and metabolic syndrome. Don't miss that. And I must thank Dr. Yogesh for his wonderful the narration of what is gastroparesis and diabetic diarrhea. Even though right now may not be able to offer much, but we need to understand there are patients who are suffering from that. An excellent moderation by Dr. Lakshmanan and Ganesh, and my panelists, Dr. Sitaram, Dr. Farooq, and Akande, and our ambassadors and delegates from all over the world. Thank you very much. I sign off now.
Thank you.
And
Thank
we'll
you. Good
meet
night,
in
sir.
May for hypertension and metabolic syndrome. Thank you very much.